Thank you very much, and good morning, everyone. If I have technical problems, I will sing for some time. I'm going to present APS Action. Most of you probably heard already about this consortium of investigators. So APS Action stands for Antiphospholipid Syndrome Alliance for Clinical Trials and International Networking. And it was born in 2010 during an international collaborative working summit in Miami, in Florida. So how it was born? So after the meeting in Galveston that was chaired by Silvia Pierangeli, the APS Clinical Research Task Force got together and they recommended that there was an urgent need for a true international collaborative approach to design and conduct well-designed, prospective, large-scale, multi-center clinical trials of patients with persistent and clinically significant APL profiles. So APS Action was created to study the natural course of disease over 10 years. However, it's been more than 12 years that APS Action is running. These patients would have or not other systemic autoimmune diseases, patients who are recruited and samples were collected at multiple sites. The protocol involved APL testing in all of these patients, but the testing was and is being done in 5 different international core laboratories. So every single sample, depending on the area where the patient is recruited, is sent to a core laboratory. And all core laboratories use the same methodology and the same kits. So the first questions that APS Action had when they were formed is, we didn't know the true APL frequency. We didn't know the reported association between APL and clinical outcomes or the reported frequency of antiphospholipid in young people with cardiovascular events or cerebrovascular events. So these are the first work that was published, estimating the frequency of antiphospholipid antibodies in pregnancy morbidity, stroke, myocardial infarction, and deep vein thrombosis, and was led by Laura Andreoli. The estimated frequency in cerebrovascular events led by Sabino Shasha, and the association between antibodies and pregnancy morbidity led by Cecilia Chigisola. And this was to give APS Action an idea of what we knew already about antiphospholipid syndrome. So what we concluded from this initial work is that it was really difficult to determine the frequency of antiphospholipid, that the association between APL and clinical outcomes was not supported by every study. There was a lack of robust data, and the variability in the test reproducibility and the cutoff definition that each center used was making these comparisons very difficult. So we had many, many methodological limitations. So we thought, or we established, that probably APS Action would be able to help improve the clinical research standards, producing high-quality collaborative studies. So initially, APS Action was formed to run clinical trials. However, with the years, we realized that running international clinical trials without the support of pharmaceutical companies is almost impossible. However, we succeed in running a very, very small clinical trial using hydroxychloroquine in the primary prophylaxis of thrombosis. In this very, very small study, that was a randomized controlled trial, we included 20 APL-positive patients who didn't have any thrombotic event. So 9 of these patients were randomized to hydroxychloroquine, and the follow-up was 1.7 years. However, this study was terminated early because we had very low recruitment. We have many problems, mainly in Europe, with the ethical committees to approve this sort of study without a sponsorship that would guarantee insurance. There was a manufacturing shortage of hydroxychloroquine at the time, and of course, due to the shortage, there was a significant price increase, and for us, as a will or voluntary group, we couldn't cover the cost. What is important is that at least we got some data, and from this 1.7-year follow-up, we had no thrombosis and no serious adverse events. So one of the most important things from APS Action is that, as I said before, we have core laboratories and all the samples are tested on these laboratories. So one of the things we needed to make sure is that all the laboratories were performing in a way that we could compare the data. So what we did is we assessed intra and inter-laboratory variability, and we evaluated the agreement between the core laboratories. And these are both of the publications, one based on ELISA results, the other one on the lupus anticoagulant testing. And what we saw is that the core lab results achieved a very good agreement. And this is very important because these results really underpin the accurate interpretation of the APS Action clinical data. So what we learned from APS Action clinically? Well, we know that 63% of the women who had as a first event an obstetric event developed thrombosis after the obstetric morbidity, and this data is really important for monitoring. We also evaluated the value of the adjusted global antiphospholipid syndrome score in our cohort. We also studied the characteristics of patients with APL positivity. We also published a position statement and management guidance on antiphospholipid positive patients for COVID. And we also study the clinical and laboratory characteristics of the Brazilian versus non-Brazilian population, and this is work led by Professor Daniele Andrade. We also realized that APS patients cluster in different groups, and different phenotypes, clinical phenotypes of these APL positive patients was discriminated. We also know that approximately 80% of our patients with clinically meaningful antiphospholipid profile at baseline remain stable after 5 years. So if your patients have antiphospholipid antibodies at medium or high titers, during 5 years follow-up, these titers will remain. But I think this is the most important work we have seen on APS Action, is that regardless of the number of antibodies, triple, double, or single, there is a high incidence of thrombotic events. And this is really important because triple positive is the highest risk of thrombosis. However, if you have a persistent single positive high titer antiphospholipid antibody present, the risk of thrombosis is also there. Also, we know that the incident thrombotic risk on the first year was 0 for those patients without a previous history of thrombosis, and 1.7% on patients who had a previous thrombotic event. And this is probably due to the close monitoring during the first year that these patients were included in the study. We also know that the patients who develop a recurrent event, most of them had triple positivity or lupus anticoagulant persistent, but we also know that in most of the cases, there was a trigger factor. So there was a low INR, immobilization post-surgery, low INR again, immobilization. A patient decided to stop the anticoagulation treatment 3 months prior to the recurrent event, and one patient had a long flight. Again, we reanalyzed this data after 5 years, and here we saw that the incidence of thrombosis was 1.68 per year in patients who didn't have a previous event, so there is a risk of thrombosis there, and 2.6% per year in patients with a previous event. And this was maintained for the following 5 years. What is important that we also understood here is that when we speak about the new events, 33% of the patients had a single antiphospholipid antibody positivity, and this is really important when we speak about monitoring. And 22% had a single lupus anticoagulant, which is the highest, the antibody that we know to give the highest risk. Also, it is important that in those who develop a new event, 56% was receiving no treatment at all. So prophylactic treatment should be very important here. In the ones who had a recurrency, and this is really, really surprising, 73% of the patients was under a subtherapeutic INR that was less than 2 at the time of the event. And in both of the cases, most of the patients had other cardiovascular risk factors, or they have a trigger event of immobilization of surgery. Overall, this data is really important when we speak about monitoring of APL-positive patients. So this is all I have to share with you today. I think despite being 12 years on the run, we have just started, and there is a long way still to go. Thank you for your attention.